Welcome to This Week in Orthopedics. This week we are covering 10 notable papers spanning 3 broad clinical areas: joint preservation and reconstruction of the knee, postoperative complications, and occupational safety in arthroplasty, and advanced diagnostic and trauma strategies. Let us dive in. We begin this week in the realm of joint arthroplasty, where several new papers challenge historical dogmas, evaluate modern technologies, and highlight unrecognized occupational hazards. First, we look at unicompartmental knee arthroplasty, where the use of patient-specific instruments or PSI has been proposed to improve component positioning and clinical outcomes. In a secondary analysis of a multicenter randomized controlled trial, sports traumatology, arthroscopy researchers evaluated the 5-year outcomes of 120 patients randomized to either patient-specific or conventional instrumentation. The investigators found no statistical difference in patient-reported outcomes, including the Oxford Knee Score, the Western Ontario and McMaster University's Arthritis Index, and the Forgotten Joint Score, between the two groups. Surprisingly, the patient-specific instrument group demonstrated a numerically higher, though not statistically significant, revision rate of roughly 14%, compared to only 5% in the conventional instrumentation group. The primary reasons for revision included the progression of lateral osteoarthritis, bearing dislocation, persistent pain, and instability. Although the study may have been underpowered to detect a true difference in revision rates, these midterm results suggest that patient-specific instruments do not offer a clear clinical or survival advantage over traditional, conventional instrumentation in unicompartmental knee arthroplasty, prompting surgeons to carefully weigh the added costs of custom guides. Remaining with knee arthroplasty, we must also consider the persistent challenge of postoperative rehabilitation, specifically the phenomenon of arthrogenic muscle inhibition or AMI, which can severely limit quadriceps recovery. Writing in knee surgery, sports traumatology, arthroscopy. A retrospective cohort study of 229 patients undergoing primary total knee arthroplasty evaluated the prevalence and risk factors for this debilitating condition. Using the Sonnery-Cottet clinical classification, the authors found that while only about 9% of patients had arthrogenic muscle inhibition preoperatively, the postoperative prevalence spiked to nearly 45% at 30 days, before declining to 19% at 60 days. The analysis revealed that a body mass index of 30 or greater roughly doubled the risk of inhibition at 1 month, while chronic symptoms lasting 4 years or more than double the risk. Crucially, having arthrogenic muscle inhibition at 30 days was the most powerful predictor of its persistence at 60 days, increasing the odds by over 15 times. Other notable risk factors for prolonged inhibition included an age of 70 or older, high postoperative pain scores at day 7, and early postoperative morphine use. Interestingly, a neutral preoperative limb alignment appeared protective, reducing the risk of early inhibition by more than half. These findings highlight the critical importance of identifying and aggressively managing quadriceps inhibition in the very early postoperative window, particularly in older, obese, or chronically symptomatic patients. Moving from the knee to the hip, we encounter a study that directly challenges a long-held surgical dogma regarding superficial wound complications. Historically, many orthopedic surgeons have operated under the assumption that a superficial surgical site infection after primary total hip arthroplasty does not truly exist as an isolated entity, but rather represents an unrecognized deep joint infection that will inevitably lead to component failure and revision. A single-center observational study, analyzing over 3,200 patients with a minimum of 4 years of follow-up, the investigators identified 27 patients who developed a confirmed superficial surgical site infection. Using both frequentist Cox regression and Bayesian survival models adjusted for age, sex, and physical status, the researchers found no statistically significant association between a superficial infection and the risk of subsequent revision surgery for any cause. The adjusted hazard ratio was 1.4, with a very wide confidence interval, and the Bayesian model indicated a mere 1% probability of an increased revision risk. This study provides reassuring, high-quality evidence that a superficial surgical site infection can indeed be successfully managed without compromising the long-term survival of the implant, debunking the absolute dogma that all superficial wound infections in hip arthroplasty are destined for deep revision. While we often focus on patient outcomes, we must also protect the health of the surgical team, particularly regarding the air quality in our operating suites. A prospective study in the Journal of Bone and Joint Surgery investigated intraoperative exposure to surgical smoke, specifically fine particulate matter, measuring 2.5 micrometers or less, during different arthroplasty procedures. The researchers monitored 83 primary arthroplasties, including bipolar hemiarthroplasties performed via a direct lateral approach, total hip arthroplasties via a direct anterior approach, and total knee arthroplasties. The findings were stark. Both bipolar hemiarthroplasty and total knee arthroplasty generated massive spikes in particulate concentrations during surgical field development, resulting in median maximum concentrations of roughly 130 and 119 micrograms per cubic meter, respectively. In contrast, concentrations during direct anterior total hip arthroplasty remained remarkably low, with a median maximum of just over 6 micrograms per cubic meter. Alarmingly, at just 1/4 of the way through the surgical time, 80% of the hemiarthroplasty cases and 71% of the total knee arthroplasty cases reached an air quality index categorized as unhealthy or worse. Hemiarthroplasties via a direct lateral approach carried over 34 times the odds of reaching this unhealthy threshold compared to direct anterior hip arthroplasties, while total knee arthroplasties carried nearly 22 times the odds. Because the surgical approach and procedure are determined by patient pathology and are not easily modifiable, these findings underscore an urgent need for robust operating room safety measures, including mandatory smoke evacuators and high-efficiency masks, to protect orthopedic teams from chronic exposure to toxic surgical aerosol. Our second theme focuses on joint preservation and reconstruction of the knee, where patient selection, precise surgical planning, and anatomical restoration dictate success. We begin with a comprehensive review in the Journal of Bone and Joint Surgery, examining the current state of osteochondral autograft transfer, or OAT, for focal defects of the knee. This single-stage procedure remains a premier joint-preserving option for active patients because it restores true hyaline cartilage and subchondral bone. The authors emphasize that the ideal candidate is a young, active patient with a unipolar defect, measuring between 1 and 4 square centimeters. However, clinical outcomes become significantly less predictable once the defect size exceeds 3 square centimeters. Furthermore, inferior results are consistently seen in older lower-demand patients, as well as those with unaddressed malalignment, joint instability, or meniscal deficiencies. When performed with meticulous technique, including perpendicular graft harvesting and flush, coplanar implantation, osteochondral autograft transfer yields exceptional results, with over 85% of patients successfully returning to sports within 6 months. The review also notes that while emerging biologic adjuncts and donor site substitutes show promise in enhancing graft integration, their long-term clinical benefits remain unproven, keeping traditional mechanical precision at the forefront of successful outcomes. This discussion of biologic solutions and evidence-based practice is mirrored by a commentary in the same journal, which notes that orthobiologics are currently at a critical crossroads. As the field transitions from initial biological promise to rigorous evidence-based orthopedic practice, clinicians must demand high-quality prospective clinical trials to justify the widespread adoption of expensive cell-based and signaling therapies, ensuring that patient care is guided by objective data rather than commercial enthusiasm. When joint preservation requires addressing coronal plane deformities, we must turn our attention to the prevention of miscorrection during osteotomy surgery around the knee. A current concepts review in knee surgery sports traumatology arthroscopy highlights that miscorrection is not merely a failure to hit a specific coronal target, but rather a complex, interrelated matrix of planning errors, surgical execution flaws, and rehabilitation variances. The authors outline critical planning factors, such as the joint line convergence angle and joint line obliquity, which must be carefully calculated to avoid creating secondary deformities. They contrast the utility of computer-assisted navigation and patient-specific instrumentation in improving surgical accuracy, while emphasizing the protective role of hinge wire techniques during tibial and femoral osteotomies to prevent catastrophic intraoperative fractures. Ultimately, the review clarifies that because no single coronal target fits every patient, individualized planning based on patient-specific parameters is essential, and future advancements in artificial intelligence are poised to help refine these complex surgical algorithms. For many young patients, joint preservation begins with the management of soft tissue injuries, particularly concomitant meniscal tears during anterior cruciate ligament reconstruction. A large retrospective cohort study of over 5,000 primary reconstructions. Sports traumatology arthroscopy evaluated whether performing a concomitant meniscal procedure impacted 2-year outcomes. The researchers found that performing a concomitant meniscal procedure did not increase the rate of subsequent anterior cruciate ligament reoperations. However, patients undergoing meniscal repair experienced a significantly higher rate of subsequent meniscal procedures within 2 years, at roughly 11%, compared to about 5% for those undergoing resection or isolated ligament reconstruction. This increased rate of reoperation and lower patient-reported outcome scores were driven almost entirely by failed repairs. Conversely, patients with successful meniscal repairs achieved clinical outcomes and symptom scores that were completely comparable to patients who had an isolated ligament reconstruction. Furthermore, lateral meniscal repairs yielded significantly superior outcomes and symptom states compared to medial or combined repairs. These findings strongly support the ongoing clinical push for meniscal preservation, but they also serve as a sober reminder of the clinical toll of a failed repair, emphasizing the need for refined surgical techniques and careful patient selection to optimize healing. Our final theme transitions to orthopedic trauma and diagnostics, where long-term outcomes and imaging innovations are reshaping clinical decision-making. We start with a highly anticipated 10-year follow-up of a Level 1 randomized controlled trial, comparing primary arthrodesis against temporary bridge plating for unstable Lisfranc injuries. Historically, the choice between primary fusion and open reduction with temporary plating has been a subject of intense debate. This long-term concise follow-up reveals that at 10 years post-surgery, there were no significant differences between the primary arthrodesis and bridge plating groups regarding patient-reported outcomes, pain scores, or physical function. However, the clinical course differed dramatically in terms of subsequent surgeries. Over the 10-year period, patients in the temporary bridge plating group underwent significantly more subsequent surgical procedures, primarily driven by the planned removal of the hardware and a higher rate of secondary salvage arthrodesis for symptomatic post-traumatic arthritis. In contrast, the primary arthrodesis group required far fewer secondary interventions. This landmark 10-year data suggests that while both techniques ultimately yield comparable long-term functional recovery, primary arthrodesis offers a more direct, efficient treatment path with a substantially lower cumulative surgical burden for patients suffering from unstable Lisfranc injuries. We conclude with an exciting diagnostic advancement in the management of pelvic trauma, specifically sacral fragility fractures, which are notoriously difficult to identify on standard imaging. Writing in the Journal of Bone and Joint Surgery, researchers developed and evaluated an edema-enhanced computed tomography technique, or EECT, derived from quantitative dual-energy computed tomography. By identifying locally increased water-equivalent density at fracture sites, this technology highlights areas of bone marrow edema. The diagnostic performance of this new technique was compared against standard single-energy computed tomography, traditional dual-energy computed tomography, and magnetic resonance imaging in 50 patients with suspected fractures. The study found that edema-enhanced computed tomography demonstrated the highest sensitivity, specificity, and overall diagnostic accuracy for both detecting and localizing sacral fractures. Remarkably, the use of this technology completely eliminated the diagnostic performance gap between highly experienced orthopedic surgeons with over 10 years of experience and junior surgeons with less than 3 years of experience. By providing clear, objective visualization of bone marrow edema, this advanced imaging modality holds the potential to significantly reduce misdiagnosis and experience-related variability in the evaluation of fragile elderly patients with suspected pelvic fractures. If you only have time for one paper this week, make it the 10-year randomized controlled trial comparing primary arthrodesis and temporary bridge plating for unstable Lisfranc injuries. This landmark study provides the definitive, long-term evidence we need to confidently counsel patients, proving that while both techniques offer equivalent functional recovery at a decade, primary arthrodesis dramatically reduces the long-term surgical burden and the need for secondary salvage procedures. Here are the key takeaways from this week in orthopedics. First, primary arthrodesis for unstable Lisfranc injuries provides equivalent 10-year functional outcomes to temporary bridge plating, but with a significantly lower rate of subsequent surgeries and hardware removals. Second, patient-specific instruments do not offer a clear benefit over conventional instrumentation in unicompartmental knee arthroplasty and are associated with a numerically higher revision rate at 5 years. Third, a superficial surgical site infection after primary total hip arthroplasty is not associated with an increased risk of long-term revision, demonstrating that these superficial infections can be successfully resolved without implant compromise. Fourth, Operating room teams are exposed to potentially harmful, unhealthy levels of fine particulate surgical smoke during bipolar hemiarthroplasty and total knee arthroplasty, highlighting the critical need for routine smoke evacuation. And fifth, successful meniscal repair during anterior cruciate ligament reconstruction preserves excellent patient-reported outcomes, but failed repairs significantly degrade patient outcomes and increase the 2-year reoperation rate, particularly for medial and combined repairs. That's your roundup for this week in orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.